The best teachings leads to best research, and the best research leads to best teachings. Through some of the best teachings that we have received from great masters, through Master Chuakoksui, we have been able to conduct this pilot study. Today, I am happy to present to you the randomized control trial, double-blind placebo-controlled study on the effects of pranic healing on chronic obstructive pulmonary disease. Loving greetings to judges and co-presenters and all the delegates here. This study was being sponsored by World Pranic Healing Foundation, India. Prana is a vital force which is needed for the body to exist. Pranic healing is an ancient science of healing people using prana. There are few studies which has been conducted on pranic healing. Of course, there are not too many, and one of them has been conducted by Vrinda, expresses that there is a general improvement was observed in all adults showing pranic healing does affect the lung function. There are few more studies only which has been conducted on effects of pranic healing. COPD, chronic obstructive pulmonary disease, is one of the important causes of morbidity and mortality, with an estimated 600 million sufferers worldwide. It has been estimated that by 2020, this would be the third leading cause of death. And of course, some assessments does say that it can be much earlier as well. And one of the reasons for COPD is chronic smoking. In this study, we have concentrated more on people who smoke, heavy smokers. The research question that we have used here is whether pranic healing will reduce COPD symptoms, whether pranic healing is effective in improving activity and impact in COPD subjects, whether pranic healing will increase the physical and psychological participation of COPD subjects, will there be an improvement in quality of life after pranic healing sessions. Let's look into the method. We have used a randomization, computer-generated randomization was used, placebo group was also there, double-blind study, participants and investigators both were blinded, and concealment was used. Informed consent was received, confidentiality was strictly maintained, incentives of 300 rupees was given to participants because for a clinical visit we needed almost the whole day. Hence, loss of work time was given for 300 for each participant on each visit. Insurance was taken. Ethical permission was duly received. Was received from Allergy Asthma Associates Ethical Committee, and this has been registered in CTRI with the following number. Inclusion criteria is male patients diagnosed with COPD stage 2 according to gold criteria, 40 to 75 years, current smokers, and smokers for at least 10 pack years. Exclusion criteria also includes participants who quit smoking during the study period, and the pulmonary function test indicated improvement during clinic visit 2 and 3 were also excluded. Details of tests are as follows. Pulmonary function tests were performed using ATS standards. ABG, ECG, and chest X-ray was done at NABL accredited laboratory. 6-minute walk test, the Hamilton rating scale for depression, St. George respiratory questionnaires has been used in the study. Let's look into the schedule of tests on visit basis. So, pulmonary function test, PFT, the oxygen saturation, 6-minute walk test, Hamilton depression scores, and St. George respiratory questionnaire was used on all the visits, all the clinic visits, and you have the other informations of ABG, chest X-ray, ECG in the table. Study flowchart. The information was given for 800 participants in 3 gramas in Mysore district. Out of them, 410 showed interest, and the consenting was done, and screening was done using spirometry. 410, and we found 29 who suited all the inclusion criteria. Later, international standard treatment was provided. Assessment, randomization, allocation was done for 21, and thereafter they were divided into 2 groups, and assessment is done for 20 participants. Here are some of the pictures from Grama. Demographic characters, you can notice here that age, height, weight, BMI, started smoking age, smoking duration, all of them are clearly indicating that it is non-significant between the groups. Medication was being provided, medical care was given throughout the study for both control and pranic group. Tiotropium and inhaled salbutamol as a rescue medicine was provided for the subjects, for the participants. Pranic healing sessions were provided in their Gramas thrice a week. Each of the healing sessions took around 20 minutes. Statistical assessments, descriptive statistics, repeated measure ANOVA, and independent sample t-test and SCRQ calculator has been used. Let's look into the results. The PFT indicates that FEV1 post a predicted value indicates that from visit 2 to 5 there is a significant improvement of 0.027. If we look from between all the visits from visit 2, 3, 4 and 5, then it is 0.07. So let's look into the St. George Respiratory Questionnaire. It indicates that the impact, activity and the total scores did show a significant change. The Hamilton rating scale for depression did not indicate, showed a non-significant improvement. 6-minute walk test, although showed a very good improvement, it was not significant. It stands at 0.199, but it's with a small number of participants, I think that's why we did not get a significant value. With a higher number, probably we would have got a highly significant value. The main findings, pulmonary function test showed a positive trend in pranic healing group subjects. St. George Respiratory Questionnaire showed a significant improvement in participants' activity, impact and total scores. Subjects in pranic healing group performed better in 6-minute walk test. Hamilton rating scale for depression showed a tendency towards improvement. In conclusion, we would like to say that this pilot study indicates that pranic healing could potentially improve the lung function and quality of life of COPD subjects as an adjunct to conventional treatment. Strengths of study. This has been a very vigorous study. We're using double-blind placebo-controlled. We had independent assessors for each of them, which improved the strength as well. Limitation, one of the major limitation is a small number, using only 20 participants. Therefore, many variables showed a tendency to significance, but was not found to be significant. This would change if a large number of subjects would be included in the study. Future directions, larger number of patients in a multi-center trial is of need. These are few references that has been used. Thank you so much.
Thank you, Shrikant, for excellent presentation. I'm happy that you have put all the points, including the ethics committee and registration, etc.
Thank you, ma'am.
I have few questions. What's your basic? You are a medical doctor or a what are you?
Okay, I come from an engineering background.
Engineering background.
Yeah, and found
You're
my
a pranic
passion,
healer.
Yes, and found my passion in pranic healing. I'm practicing pranic healing since 18, 19 years now.
Okay.
Yeah.
And my question is, I have few questions. One is I want to know about the double blindness. How can you say it's a double blind? Number 2, these results shows improvement in the pulmonary function test. Okay. What is the mechanism behind? What do you propose? Sure. These 2 questions I have.
Yeah. Dr. Patsarthi was, he actually did the randomization, and the investigator, Dr. Mahesh, was not being informed about the allocation aspects. So that's how we maintained the blinding. Both participants were totally blinded. Okay, when it comes to application of pranic healing, sham pranic healing was applied. So we applied pranic healing session for person in a pranic healing group. Similar kind of gestures were used, and 20 minutes was utilized, and no energy was being projected for person in the control group. So that made it as a sham pranic healing. So patients were completely blinded.
Okay, even the principal investigator did not know whether that person has got pranic healing or a sham pranic healing?
No, no.
Okay. Were they on any medication? It's an add-on therapy or it's independent of medical therapy?
It's an add-on therapy. Tiotropium and
okay.
inhaled salbutamol was provided.
Okay.
And all the care was given.
Any mechanism, can you propose what could be the reason why there was increase in the pulmonary function, improved pulmonary function test?
Well, when we remove the used up energy in the lungs, automatically the energy flow is easier. When the energy flow is easier, it is easy for the flow of prana. When the prana flow is easy, automatically inhalation becomes easier. Henceforth, we can see such kind of a positive trend.
Last question, sorry. This pranic healing is the same for pulmonary disease, cardiac disease or any skeletal muscle disorder? Or do you have any different types of pranic healing? This is for my interest I'm asking.
Thank you for the question. The pranic healing protocols differ for each ailment, and most of these protocols have been provided by Master Choa Kok Sui. The books have been written almost 25 years back.
I had one question. You had a screening population that you screened 410.
Yes, sir.
But you only accepted 29. That's quite a drop between screening and impaneling into the study. Why was there such a large drop?
Because we had too much of inclusion criteria. Would prefer to use this slide of inclusion criteria.
You have to go to the flow chart.
Yeah. So inclusion and exclusion criteria, if you look into it, it has. Yeah.
That's next.
No. Inclusion and exclusion criteria, if we look into it, we had male patients that to COPD stage 2. Getting COPD stage 2 was tough. For us, we could easily get stage 3 in those 3 grammas. And many times, pyrometry tests, the villagers couldn't perform as we actually asked them to do. So the consistency was not found, and hence there was a lot of dropouts. And many people said that, well, now they are more aware of some of the consequences of smoking, and they would like to quit smoking. So even though they gave the consent, soon after they decided that they'll stop smoking. And when somebody says they'll stop smoking, we can't include them. So that's how there was a drastic reduction in the figure. It's because of the inclusion and exclusion criteria, which was very strictly maintained.
All 400 were male?
Yes, all the 400 were male.
I have one more question. The mechanism of pranic healing, because pranic healing and pranayama are two different things completely.
Yes, sir.
This talks about the negative energy which is accumulated in the pranic body. And from that, elimination of that improves the personality overall. That's the whole phenomenon, if I understand it right.
Yes, sir.
But you can actually throw some light on the mechanism.
Sir, do I have time? Okay. Hence, it was not been included, sir. We have been given a very short time. Thank you.
This is a standard time word over,
Yes,
not a short
Yes,
time. So, good presentation for all of us, youngsters. The slides particularly, I think you can just copy it. So, the flow, I mean, you cover virtually everything. That's something very, very interesting for young and an engineer to pick up all of the details in medical clinical trial. Very good. Two, you also touched upon a very important area. Although it's pranic healing, I would think that it is in line with how acupuncturists think. You know, in acupuncture, there are loads of paper. There are about, I don't know how many times more papers than yoga or Ayurveda, that acupuncture research is available. Body of literature is huge. Same premise, that there is chi, there is meridian, there's no physical correlates to all of that, but still people have really gone ahead and demonstrated cause and effect. So to that effect, this is really a good attempt, well done. But then of course, the whole lot of clinical issues here, because you're looking at some of the organic changes by an intervention which is very, very subtle. That raises good deal of questions, something that we need to really carefully consider. But then there's one question that I have, is when you have sham pranic healing, the experimental group, they know the fact that at some point of time they would have real pranic healing, right? So like Dr. B. M. Hegde made a point yesterday, that the fact that they are getting pranic healing in one of the sessions is good enough placebo to get the effect in all the subclinical parameters that you've taken. Most of your variables are subclinical. They're not primary organic structural changes that you're looking at in COPD. So looking at depression or anxiety or functionality index, all of it is something that can just be induced by placebo. So that's a big limitation that you have. That's something that you need to correct in a larger study. Otherwise, the flow, the attempt is very good. Thank you.
Thank you so much, sir. Even though the entire study duration was for 1 year, we made sure that those in the control group did receive a good number of healing sessions. So for visit 6 and 7, they were provided, even people in the placebo group, people in the control group also did receive pranic healing.
So then you need to say this as a crossover trial. So those details can be added later.
Yes.
But that single limitation of not clearing the sham and real pranic healing itself can be a really big flaw in this study. Something that we can discuss and fix it. Otherwise, you can expand the study on a larger sample.
Thank you so much.
Thank you, Shrikant Joyce. I would like to call upon paper ID 85, title, A Clinical Evaluation of Efficacy of Arogyavardhini Rasa and Marichyadi Taila, External Application along with Pranayama in Eka Kushta WSR to Psoriasis.
Good afternoon to you all, respected chairpersons, delegates. I welcome you all for my presentation, a clinical evaluation of efficacy of Arogyavardhini Rasa and Marichyadi Taila external application along with Pranayama in Eka Kushta with special reference to psoriasis. Coming to introduction, Eka Kushta, it is a type of Shudra Kushta described in different classics of Ayurveda. It is Vata Kapha. The predominant dosha which is involved in the development of Eka Kushta is Vata and Kapha. The clinical symptoms resembles with the clinical symptoms of psoriasis. It is a chronic, genetically determined inflammatory proliferative disease characterized by dry, well circumferized silvery scale in papules, plates with various size with spontaneous remission, relapse and seasonal variation. Coming to its prevalence, in world population, around 2% of the population is having psoriasis. Coming to India, it is around 1.5. Psoriasis is a multifactorial disorder associated with significant psychological distress, social stigmatization, psychiatric morbidity and other psychosocial factors. Present now, the medicines available are not very effective and cannot be used for the long-term management because of their side effects. The medicines which are used in Ayurveda are safe and being practiced since thousands of years. Coming to type of study, its study was an observative clinical study to evaluate efficacy of Arogyavardhini Rasa and Marichyadi Taila external application along with Pranayama in Eka Kushta with special reference to psoriasis. Source of data, 50 patients of either sex were selected from OPD of STM Ayurveda College, Hassan. After the screening, the inclusion and exclusion criteria were duly considered before the inclusion of the patients for the study. Selection of patients, after fulfilling the criteria set in the forms of inclusion and exclusion criteria, total 50 cases presenting with classical signs and symptoms of Eka Kushta, that is psoriasis, were selected for the study. Coming to diagnostic criteria, cardinal signs of Eka Kushta, that is Masya Shakalopaba, that is lesion resembling the scales of fish, and the other symptoms, that is patchy circumference skin lesions with erythematous well defined dry silvery scaly papules, and the plaques were appreciated before their inclusion of the study. Patients were also seen for the Candle-Gray sign and Auspitz sign. Inclusion criteria, patients were seen for the signs and symptoms were appreciated in all the patients before their inclusion. The age group between 15 to 60 were included for the study. Both gender were included in the study. Exclusion criteria, the chronic cases more than 5 years, the patients with secondary systematic involvement like psoriatic arthritis, patient with secondary systemic disease like diabetes and hypertension, the Pregnant woman and lactating mother were not considered for the study. Coming to posology or the dosage, the Abhyantara Prayoga, that is internal administration of 2 tablets of Arogyavardhini Rasa, that is one Ayurvedic preparation which is used for the treatment of skin disease, used thrice daily, was advised with Sukoshna Jala, that is lukewarm water after the food, and Bahya Prayoga, that is the external application of the oil, that is Marichadi Tela, was advised to apply as per the size distribution of the lesions. Regarding pranayama, the daily early morning for about 30 minutes, the pranayama includes Nadi Shuddhi pranayama, Surya Nuloma Viloma pranayama and Kapalabhati pranayama were advised for the patients. Coming to study duration, the both 3 modality used for the 30 days. Assessment of results. Assessment of results were done on the basis of subjective and objective parameters before and after the treatment. The outcomes of the observations were analyzed statistically for p-value using paired student t-test. These are the subjective parameters. The first one, scales. The gradings from score 0 to score 4, from no, mild, moderate, severe and extensive. The second one, dryness. The third one, thickness of the lesions. The fourth one, roughness. The fifth one, itching. Coming to objective parameter, the PASI score, that is psoriasis area severity index, were used for the measurement. Coming to observation, these are some of the 2 important observations I have seen in my study, that is nature of work. The maximum patients were from the stressful working environment. Regarding the type of food, the most patients were mixed diet. In Ayurveda, there also significance of Kshira and Matsya, that is milk and fish in the development of skin disease. Regarding the result, the scales were shown the highly significant result with the p-value less than 0.001, the dryness highly significant with the p-value less than 0.001, the thickness highly significant with the p-value less than 0.001, the roughness of the lesion with the highly significant with the p-value less than 0.001. Coming to itching, the highly significant with the p-value less than 0.001. Regarding the PASI score, that is also highly significant with the p-value less than 0.01. Coming to overall result, there is a complete remission was not seen in any patients. The best response was seen in around 33 patients. Around moderate response was seen in 10 patients. The mild response was seen in 7 patients. And all the patients were seen best to mild response. Coming to discussion on action of drugs and the procedures, the Arogyavardhini Rasa, it is the classical medicine which was explained for the treatment of skin disease, that is explained in Kushtadhikara in the context of all these skin disease. That the medicine used. Regarding next one, the Marichadi Taila, there is a oil preparation which was used for the external application, directly acts on the skin by its Ushnavirya, that is hot potency, that reduces the Vata and Kapha. These are the 2 doshas which are responsible for the development of Ekakushta, that is psoriasis. Regarding the pranayama, that is Surya Anuloma Viloma pranayama, Bastika pranayama, these are responsible for the development of Ushnaguda in the body. This Ushnaguda is considered as the Vata and Kaphara. They are, and these pranayama also effective in the management of stress. Regarding the other observation, on 6th day of the treatment, itself the chief complaint, that is Kandu, the itching was reduced 50%. On 8th day, after the application of Lepa, the total relief, application of Taila, the total relief from the Kandu was noted. Then the signs of Parushata and Rukshata were observed to decrease slowly on 8th to 10th day. The patients were satisfied totally with the treatment, as itching was suddenly relieved due to the application of oil. The additional effect of treatment was found to induce good sleep, as the itching was reduced during the treatment. Coming to conclusion, the Ekakushta, which is a type of skin disorder, they resembles with the signs and symptoms of psoriasis, which is explained in the modern science. Regarding the administration, the Bahir Parimarjana Chikitsa, that is the external application, is inevitable in the skin disease, especially in the management of Ekakushta. Regarding the Arogyavardhini Rasa, it is considered as effective in the management of Ekakushta. Coming to pranayama, it is effective in the management of stress. In the full study, there were no adverse reactions were reported in the study by the administration of Arogyavardhini Rasa or after the application of Marichadi Taila external application. These are the references. Thank you.
So there was no control group in this study?
Only one group with 50
Just one
patients.
group, okay. So whenever you do a study with no control group, then you need to compare some degree of what is in the literature. How did the results of your study in terms of the percent improvement and the time frame of improvement, how did the results with your intervention compare with conventional drug therapy?
No, we prepared one standard protocol for the treatment of psoriasis.
The question is, how does this compare with
No, before and
allopathic?
after- before and af-
How do the results compare with allopathic medicine from standard treatment, from other literature?
In future, you have to make one standard group using.
You didn't understand the question. The question is, you have a set of therapy that you're testing now. Now, currently, there is a recommended conventional or allopathic treatment for psoriasis, right? That is recommended. Now, how this result would compare with that standard treatment already available for patients? You don't
Yeah.
know. Did you check that?
No,
You must. Whenever there is a no control group, that's what Dr. Khalsa is saying, that we need to compare with the current recommendation. There is already a prescription available against which we are testing something new. So if something new has to be prescribed or considered, this should do better than the current conventional care.
Usually in modern treatment, there is no particular standard treatment. They use only corticosteroids.
No, of course there is. You can't say that. So of course there is a set prescription. That's something that you should check. Right? The other thing is, whenever we do Ayurveda research, particularly looking at both internal and external application, you need to separate them out. And all the more in your study, you have pranayama. So, if you really look at pathophysiology of psoriasis, pranayama alone can give more or less the results that you're talking about. So now we really do not know how much of this result is due to pranayama or from external application or herb, that is internal medication. We do not know. So it could be 70%, as a yoga researcher, I would say it could be 70% from pranayama and 30% from those, 20% from external application. So I would argue that I don't need your internal medication, because then I have the problem of toxicity, drug-herb interaction, and so on and so forth. So lesson is, whenever you're looking at Ayurveda research, separate the internal and external medication, number one. And when you have and best design for you particularly would have been external application and pranayama alone. Then those are complementary. So you're doing pranayama and then just an external application. Whereas now you have internal medication, external ointment and pranayama, so you really kind of created too many confounding interventions, which we don't have. Otherwise, again, please look at previous presentation slides. The same study can include all of that. The flow can be much better than what you've done. Thank you.
Thank you, Dr. Sandesh Shetty. I would now call upon the next presenter. Neurohemodynamic effects of yoga practice in healthy volunteers. The next would be Smita Malaya. Please be ready.
Of yoga practice in healthy volunteers, a FNRS study. Yoga is a multi-component practice that includes various physical postures, breathing regulation, deep relaxation, meditation, and mindfulness techniques. Yoga practices have also shown to improve the social cognition by the release of neuropeptide known as oxytocin. In this field, various hemodynamic responses studies have been studied with respect with functional magnetic resonance imaging, and has been shown that hemodynamic effects have also been seen to change with yoga. In this respect, to correlate the hemodynamic changes, a new device has been come into play, which is functional near infrared spectroscopy, which has been seen and standardized in singularly or in combination with fMRI and has been seen to correlate the results of fMRI. FNIRS is a non-invasive imaging technique offering measures of regional blood oxygenation state in cortical tissues. In the current study, we try to examine the potential effects of yoga on mirror neuron activation using FNIRS. Mirror neurons are the specialized brain cells which are activated similarly when a person himself performs an action or when a person observes the same action being performed. As you can see in the image, the activity in the brain of the monkey during when he grabs the banana and during when he sees the banana being grabbed is the same. In humans, these neurons are found in ventral premotor cortex, parietal cortex, inferior lobule of parietal cortex. So in this study, we aimed to look into the activation changes pre and post yoga of these mirror neuron activation in the area of ventral premotor cortex. For this studies, we included 17 consulting healthy adult volunteers who participated in the yoga module of 1 month and participated in yoga for 1 hour per day, various yoga asanas, relaxation exercises, pranayams and chanting meditation was done. The methodology, FNIRS system used for this was a continuous wave FNIRS operating on 2 wavelengths of 760 and 850 nanometers. A total of 8 sources and 4 detectors were used, yielding a total of 10 active channels which were placed symmetrically bilaterally, yielding 5 channels per hemisphere. The sampling frequency was 15.6 Hertz. The areas covered were dorsolateral prefrontal cortex and the ventral premotor area, which were located with the help of 1020 EEG system. The mirror neuron activation task during FNIRS was administered using ePrime software. This slide shows the geometry of the arrangement of optodes. The red color dot shows the sources, which are the infrared light emitters, and the green color dot shows the detectors, which detect this infrared light after being reflected from the brain cortex. So these covered bilaterally the area of dorsolateral prefrontal cortex and the ventral premotor cortex. The mirror neuron activation task, the task was total of 5 minutes where 2 30-second videos and an image of a hand and cup were shown. These videos and the images were randomized and were shown 3 times for 30 seconds each. The videos served as a dynamic control and a dynamic pincer gas video. As you can see, the videos won't work in this. The file is already embedded in this. Okay, anyways, the files are not working in this. In the pincer gas task, what was happening, a hand was there and a cup of milk was there. And it was shown that a hand was picking up a cup of milk. In the dynamic control, only the hand was moving in the table and the cup of milk was kept constant. In the image, in the static image, there was a static hand and a cup of milk was there. The data was processed using NIRS lab software. A fixed effect GLM model was used for analysis. The channels were inspected for spike artifacts, any motion artifacts, and the bad channels were removed. A band pass filter of 0.01 to 0.2 Hz was used, and a baseline rest of 60 seconds was used for analysis. As can be seen, after analysis, it was seen that there was a significant increase in the activation in the left pre-ventral motor cortex following yoga in subject who participated in at least 10 yoga sessions. There was no change in the subjects who participated in yoga sessions less than 10. And this significant activation was seen in the contrast where the active state was shown and the static state was shown. I'll show this again. As you can see, initially, the left ventral premotor cortex area, which is blue in color, is least activated. The red color shows the maximum activation. But after post-yoga, there was a change in color from blue to red, which shows that there was an increase in activation post-yoga in the left ventral premotor cortex. And again, the image of pre and post contrast is from a single individual. So in conclusion, we can say that the observation and imitation of yoga practices during 1 month training may cause changes in the activation pattern of the mirror neurons. Since the sample size was very small, so this preliminary data can serve as a dose-based response. Again, since the sample size was small, replication and further systematic evaluation is large sample is required to further validate the findings. These are the references. Thank you.
A good study, very well thought of,
Thank you, sir.
particularly looking at mirror neurons is something very, very important, not in just meditation studies, in all of the consciousness studies.
Yes, sir.
Just neurobiology of consciousness, it's so much more important. And in all of those patients who would have those brain areas damaged. I would say, I'm sure you're thinking of clinical applications of these studies.
Yes, sir. So studies, we have started studies where we are working with schizophrenia patients.
Good.
So they are also undergoing yoga. So there is a baseline where we do this FNIRS, and after a period of 1 month and 3 months, we'll again be repeating FNIRS. So to check what is the difference in activation in the follow-up.
Excellent. So most of the confounding variables were well controlled, I must say.
Thank you, sir.
And you did take, again, artifacts is one of the major, although this is an advantageous variable, but artifacts are an issue still.
Yes, sir.
And I'm not going to ask you how you excluded those channels and detected all of that. That would take time. But then the fact that you mentioned that is a good thing. But then the one question that I have
Yes, sir.
is whenever you talk of dose-dependent activation,
Yes, sir.
whether it is in medication or brain activation, you would have to very strictly define the dose of the intervention.
Okay, sir.
So just saying that 4 sessions and 10 sessions is not sufficient.
Yes,
There
sir.
could be people who would really master yoga in 4 sessions, and there could be people needing 20 sessions not knowing anything.
No. Yes,
Right?
sir.
So there are number of ways of looking at the proficiency in yoga rather than just looking at the count of sessions.
Okay,
So I think you should look at it.
Yes,
But
sir.
once done, then I think you can talk about dose-dependent variations.
Sure, sir.
Good. Congratulations.
Thank you, sir.
So how did you determine whether to use less than 10 sessions or more than 10 sessions as a criterion for comparison?
Sir, there were 17 subjects we have taken. Sir, so there was, we checked, we had, the session went on for 1 month. So we have participants who participated in only 4 sessions. There we had participants who participated in 5 sessions, in 10 sessions, in 15 sessions, in 20 sessions. So we did the analysis for 5 sessions, we did the analysis for less than 10 sessions, we went for 15 sessions, we went for more than 15 sessions. So there we found that when the subjects went for less than 10 sessions, there was no change in the activation. But once we crossed the number of sessions to 10, then we could pick up some of the activations. So this is how we went upon 5 sessions, 10 sessions, 15 sessions, and most of the subject, the mean sessions, which I think in this 17 subject it went on to, was around 15 to 17 sessions only.
So one criticism of that technique is that you are sort of determining your criterion between the groups post hoc, which
Yes,
is
sir.
you're sort of selecting the data afterwards, which when somebody could argue that this is not the best way to do it, that you should establish before the study that we are going to compare those that do less than 10 with those that do more than 10, and then you do the analysis. So there could be an argument as a criticism for that. The other way to do this, you presumably have a score for each individual subject.
Yes, sir.
So perhaps you could plot that against the number of sessions that they
Yes, sir.
studied, and then see if there's a statistically significant regression.
Yes,
If there's a significant correlation between number of sessions and the change in the score.
Yes,
Did
sir.
you do that?
No, sir, we did
Okay.
not do that.
Thank you.
Thank you, sir.
Thank you, Harlin Chabra. Moving on with the next one, Smita Malaya. Paper ID 125. Title, Vivekananda Yoga Program for Patients with Advanced Lung Cancer and Their Family Caregivers. The next would be Archana Purushottam. Please be ready.
Good evening. My respects to honorable judges who are here and my dear friends. I'll be presenting the paper on Vivekananda Yoga Program for patients with advanced lung cancer and their family caregivers. This study was conducted at MD Anderson Cancer Center in Houston. Background: we know lung cancer is the leading cancer in America, men and women combined, and it's also the leading cause of cancer death in US. It's also one of the leading cancers in incidence and mortality around the world. And even though we know that mind-body practices like yoga, tai chi, meditation has a significant improvement in quality of life for cancer patients, these studies have only looked at the patient and has not included the caregiver who is also open to a lot of stress and burden at the time for caregiving. So we thought that to look at in this study, we will look at the approach including the primary caregiver, which is most of the times the spouse or an immediate family member who will be there through their cancer journey. For this specific study, we recruited 9 couples, one of them with non-small cell lung cancer, stages 1 through 3B, and they had a physician-rated oncology group performance status of greater than 2, which means at least they will be eligible, they will be able to do some physical activity like yoga when they're going through this vigorous treatment. And 56% of our patients were male, and 66% of them had spouses, which is their husband or wife, as their primary caregiver. The mean age for the population was 62 years for the patient and 59 for the caregivers who also participated in the study. Feasibility data, as this was a study that looked at the feasibility and efficacy of this program, 15 out of 28 approached patients consented for the study. So we just had 54% of consent rate. The main reason being that we also wanted a caregiver who would stay consistently throughout their treatment with them. So most of the patients had a changing caregiver, which would not allow them to be participating in the study completely. And 9 out of the 15, which is 60% of the patients completed the program, giving us pre and post data that was required. 2 patients were found ineligible after the recruitment, and 4 withdrew due to time and other constraints that they couldn't make. A mean of 10 sessions, a range of 4 to 14 sessions were attended by these patients. Participants rated the program as very useful. About 89% of them rated very useful. Immediately after the sessions, they also rated the program with relaxed, calm, and happy, which was one of the Bohr scale that we used to measure the difficulty that is required to do this program. Patients reported low levels of pain, fatigue, distress, exertion during the intervention, which was important, so patients with advanced cancers can also participate in yoga programs. And for the program, the intervention itself, this was intervention based off of Vyasa, so it's called Vivekananda Yoga. We had 15 sessions that we designed to offer through a time of 3 to 5 weeks with 60 minutes each intervention. And the intervention consisted of joint loosening, postures followed by deep relaxation, pranayama with nadhanusandhana, meditations which focused on the aspects of acceptance and interdependence and love and kindness between the couples. Some patient results on the anxiety, depression, and somatization, which is a brief symptom inventory that we used to assess the symptoms of these patients. There were significant changes in anxiety for patients with a p-value of 0.04, and also in MCS, which is their mental scores, improved after the intervention. The effect sizes were medium for benefit finding, which is basically making a meaning of their cancer experience, which is D is equal to 0.64, and small changes for sleep disturbances using PSKI, and spiritual well-being values 0.36 and 0.31 respectively. For caregivers, which is also the number we had 9 caregivers. For caregivers, we had a very significant improvement in PISCI, which is their sleep disturbances score, and p-value 0.02, and medium effect for physical quality of life that we measured using SF-36, value 0.50. Discussion. Even though this is a very preliminary pilot data, which is just using one group, we didn't have a control group, for feasibility and preliminary efficacy was proved using this. When we look at supportive care therapies like yoga, which needs to be integrated into the mainstream, not just the efficacy is important, but also the safety, acceptability of the program is very important with the patient population. So since we had about 89% of patients rating it as a very, very useful program, and given the high symptom burden of cancer patients, especially advanced lung cancers, where we had all stage 3 lung cancers participating in this, and going through aggressive treatment protocols of chemoradiation, we expect their quality of life to go down, and there is research and literature to back that. Even with that, slight improvements in reduction in anxiety and improvement in their mental health score, I think is a very good direction for us to continue to look at in these areas. And even for caregivers, the burden, they have clinically significant levels of sleep disturbances, depression. So if these programs where we include both the couples, husband and wife, to improve their interdependence so their care can be better, these can form a very good foundation to look at this population of dyads with cancer. So we start including not just the patient in the care, but also the family caregiver primarily. So the outcomes of patient and their journey through cancer can be made easy. Conclusion, dyadic mind-body intervention delivered to lung cancer patients and caregivers was feasible and potentially effective. Future studies with randomized control trials and larger numbers with the right kind of interventions is required to look at this data in a larger study and being applicable in, that can be replicated in other populations too. Thank you.
A few cancer patients personally and who are in an advanced stage, and then the recommendation by an Ayurvedic doctor was to be on strict vegetarian diet, that is uncooked diet, and afterwards to be on turmeric 4 times a day, once morning empty stomach, in the mid-noon, evening and the night. And in a matter of about 48 days, she completely came out of that. And the whole process happened in Rishikesh. So I was surprised to know that any of the cancer presentations which I saw in the last couple of days, this mention of turmeric is missing. So I was just wondering, why is that such a great elixir, a panacea, is not actually taken into consideration?
There is a lot of turmeric research, if I can answer that. Oh, okay. Okay.
I had a question. What, I assume there have been other studies with cancer caregivers included?
Yes, we actually, after this, we have a randomized control trial that we are doing with the same advanced lung cancer population that we are recruiting.
But other groups, have other groups published studies with caregivers as well?
This is almost the first or the second study that is including caregivers in cancer population. So there was absolutely data lacking in integrative medicine to look at mind-body practices, including caregivers in cancer population.
And how did your study compare with the other studies that have been done so far?
The only study that was done was a Tibetan yoga trial, which was done from our own group, where we had similar results, but the results with the patient population had greater improvements, significant improvements in benefit findings. So that was a slight difference, probably based on the meditation aspects that were included in Tibetan yoga versus Vivekananda yoga program.
And this specific type of cancer, has it been studied with yoga before?
Non-small cell, I think yes. Not sure. Yes. Yes.
Yeah, the answer to that question is yes. Okay. I think you did not have a slide on Vivekananda Yoga, what it constituted. Did you?
Yes.
Or I missed? Okay, fine. Now, the other question that I have is, when you say caregiver, are they spouses of these patients or are they different ones?
66% of them were spouses, but because it was difficult to recruit spouses, most of the spouses were at home taking care of families, and patients would be away for
But still
treatment.
66% of them
Were spouses, yes. But we still included a primary caregiver who would be a close family member for the patient.
And they proxied for couple yoga?
Yes.
Yes?
Yes.
Okay. Okay. So, I think otherwise it's a
Improvement.
clean preliminary data.
Yes.
Again, I saw a reference. Is it also published, this
Yes.
data?
Integrative therapies. I will
Yes,
update
again, I
that.
just saw the year.
Yes.
I would recommend that you put the full reference whenever it is published,
Okay.
so that we do know that even though it is a preliminary data, if it's published, it's done well.
Yes, it is published in the integrative therapies.
Yes, I think I saw that. But I think you should give the full reference so
Full
that
reference.
students can easily avail
Okay,
and refer for all the details. Thank you.
thank you, sir.
Thank you, Smita Malaya. The next participant, Archana Purushottam, paper ID 201, title, Standalone Ayurvedic Treatment in Acute Ischemic Stroke, a non-randomized controlled trial. The next would be Dr. Geeta Shetty, please be ready.
Good afternoon. I'd like to first of all thank the organizers for this opportunity to present our pilot study on standalone Ayurvedic treatment in acute ischemic stroke. In India, we have a virtual stroke epidemic. Stroke is the commonest cause of major long-term disability. So what do we have to treat stroke with in allopathy? We have very limited treatments. The only proven treatments can be applied within 8 hours, no longer. Even in the United States, this is data from about 8 years ago, only 2 to 3% of stroke patients got to a capable hospital in time to receive these treatments. Of those who receive it, only 12 to 25% of patients actually benefited from the treatment. Plus, there are risks to this treatment, including hemorrhage and such serious adverse effects, including hemorrhage in the brain. So we need better options to treat stroke. In India, lack of access, late arrival, and financial constraints ensure that practically no stroke patients receive these treatments. On the other hand, a survey at 2 major tertiary hospitals in India showed that over 1/3 of stroke patients reported receiving alternative therapies, of which Ayurveda was the commonest. Now, this does not even include any of the patients who got exclusive Ayurvedic therapy because this was done at an allopathic hospital. Now, Ayurvedic stroke therapy, stroke is described as pakshaghata in the classical textbooks. Diagnosis and treatment are based on tridosha theory, just like the rest of disease treatment in Ayurveda. They do have the concept of the earlier it's treated, the better the outcome is. This resonates very well with the time is brain concept in Western medicine. Classical Ayurvedic treatment, in comparison with allopathy, is accessible, more affordable. It has no strict time limit, and there are no known serious adverse effects. So for the average person in the developing world, this is probably much more reachable, much more accessible. So is Ayurvedic stroke therapy efficacious? There are 2 studies in the literature on Ayurvedic therapies in stroke. One was a pilot study on marma, which is the Ayurvedic equivalent of acupressure, used as an adjunct in stroke patients. The other was a study of which Dr. Satyaprabha here was the senior author, where they looked at adjunctive Ayurvedic therapy and showed that it improved cardiac autonomic dysfunction in stroke patients. So there is no literature on standalone classical Ayurvedic therapy in acute stroke. So we started the study to answer 2 questions. One, is standalone Ayurvedic therapy safe in acute ischemic stroke patients? Two, is it feasible to conduct a larger randomized control trial of Ayurveda in acute ischemic stroke? So here is our study design. We had a two-cohort prospective study design. We had to recruit patients at two different sites. No allopathic hospital in India that I'm aware of provides standalone Ayurvedic therapy. So we had recruitment at an Ayurvedic hospital of 20 stroke patients. This was our study design. So we aimed to recruit 20 patients and 20 patients at CMC Vellore, which is a well-known allopathic hospital. Both cohorts were to get in-hospital treatment according to that system of medicine. After discharge, they were going to be given home medications according to that system of medication, plus they were advised rehabilitation therapy in both arms. Follow-up visits were to occur at 1 and 3 months. Our primary outcomes were mortality at 3 months and NIH stroke scale scores. Secondary outcomes were non-fatal adverse events, modified Rankin scale and Barthel index. Statistical comparison was done on an intention to treat basis using the last observation carried forward method of imputation when we couldn't get data. I must mention, when patients were unable to come for the 3-month follow-up, we made an effort to get follow-up to the extent possible over the telephone. This is our inclusion and exclusion criteria. I will just point out a few. We focused on anterior circulation ischemic strokes with a moderate stroke severity represented by an NIHSS score of 6 to 25. The patients should have started treatment within 72 hours of the stroke, and they should have been able to get an MRI within 10 days of the stroke. We excluded patients with fever within the first 4 days of admission because several steps of the Ayurvedic treatment could not be used in patients with fevers. So this is the Ayurvedic treatment protocol. The first phase was a Pitta Shamana, or treatment of the control of the Pitta. After that, they moved on to a Kapha Ama control, and the final phase was a Vata control with nourishing treatments for rejuvenation of tissue. This was based on the Sushruta Samhita classical description of treatment. These are the interventions for those who aren't as familiar with our Ayurvedic terminology. These are the interventions that were used. I would just like to point out the intranasal administration of herbal medications. This is one of the earliest steps done within the first hour of the patient arriving at the hospital. Interestingly, Western medicine has in recent times realized that intranasal administration is the fastest way to get medications into the cerebral circulation. So we now use it for migraines. Centuries ago, they were using the same thing for stroke patients. Here is our enrollment chart. We did screen several more patients than we enrolled, so I'll explain why we had to exclude several of them. First of all, we only enrolled 13 patients in our Ayurvedic cohort because midway through our study, a government-sponsored insurance scheme, health insurance scheme, that covered Ayurveda was withdrawn. So there was a big drop in the numbers of stroke patients who were coming to the Ayurvedic hospital. The exclusions were primarily because patients came too late, or they had an NIH stroke scale that was either lesser or greater than we had planned to include. In the allopathy cohort, because it was a tertiary hospital, they had several posterior circulation strokes, which are the rarer strokes, so because they're a referral center. So there were many more exclusions for that reason. Here are the baseline characteristics. Although we had small numbers, they were fairly well balanced, except in these three criteria. The pre-stroke disability was higher in our Ayurvedic cohort. The initial NIH stroke scale showed that the allopathy cohort had more severe scores, strokes, and the time to treatment was much lesser in the allopathy group because our Ayurvedic patients tended to come in later. Outcomes showed a very well-balanced mortality rate. There was not much difference in the improvement in NIH stroke scale either. Non-fatal adverse events were higher in the allopathy group, with 1 recurrent stroke and 1 post-stroke seizure. None of them reached significance though. I'll just finish up. We did a Euclidean matching between the cohorts to correct for these baseline imbalances, specifically with respect to initial NIH stroke scale, age, and time to treatment. This resulted in 11 pairs that were reasonably well matched. This is just to show that now none of the criteria reach significance in terms of differences. The outcomes again show no significant differences either in safety or in efficacy. I'll skip over this. This was the BP in response to treatment, just to show that there was nothing very different between the Ayurvedic and the allopathic group in terms of how the blood pressures ran. So standalone classical Ayurvedic therapy of acute ischemic stroke is safe. A randomized control trial of Ayurvedic therapy to study the efficacy of Ayurveda is feasible. I'd just like to acknowledge our funding institutions, INSTEM and IAIM, and also thank Professor H.N. Nagaraja of the Ohio State University for his inputs into statistical analysis. Thank you.
Thank you for your good presentation. I just wanted to know whether they had any allopathic treatment before they came to the Ayurveda. Because it was 72 hours and nobody will be there for 3 days when they have the stroke. So that is my question.
Actually, ma'am, you would be surprised how there would be people who come without any treatment, but there were a certain number of patients who did have outside treatment. It was very difficult for us to get any information on these treatments because typically it's a clinic. They say they gave us some injection, some medicine, and then they don't have the details. But this was true also in the allopathic cohort. So in both cases, there was a small number, probably, 72 hours was the upper limit. So several of them, in fact, many of them came in on the first day. But there were a few, so maybe about 3 to 4 in each arm, who had gotten treatment outside and then came.
So typically again, obviously a very well done presentation by a faculty. The typical prescription by WHO is 12-week rehabilitation. And we have week-wise treatment objectives, what can be achieved post-stroke. And I see here you had 21 days intervention. So why was it not considered either in allopathic intervention group or in Ayurvedic group, considered as 12-week as a feasible time to go all out and get the best reversal of disability